Succes i veterinær praksis, podcast nummer 96. Hej, velkommen til. Dyrlæge Søren Pejstrup her. I dag skal vi snakke om noget af det, som vi alle sammen står med hver dag, eller i hvert fald næsten hver dag. Dyr i narkose. Og det gælder både om det er i fuld komplet anæstesi med alt, hvad der hører til, eller om det bare er en simpel let sedation til et kloklip eller en skåret trædepude, så er der noget for dig i den her podcast. Vi skal snakke om at monitorere dyrene under narkosen, hvilke småting vi kan nøjes med, og hvilke 3 vigtigste parametre vi skal holde øje med overhovedet, og så hvis vi løber den fulde linje ud og skal have det hele med. Og jeg prøver at stille alle de dumme spørgsmål i dag, både fordi, at jeg fra tid til anden, for at sige det som det er lidt på dybt vand. Jeg har også med det her at gøre, og føler, at jeg har sådan rimelig styr på det, for at være ærlig. Men der er også områder her, hvor jeg synes, jeg kan gøre det bedre. Så jeg prøver både at stille alle spørgsmålene for at få alle detaljerne med, og du kan måske også godt fornemme, at jeg steder ikke helt har styr på tingene. Så har jeg i hvert fald været så ærlig, som jeg kan, og jeg håber, det bliver en fordel for dig, i det, at du så måske får alle detaljerne med. Jeg ved, at jeg siger det tit her i introen, men jeg anbefaler dig klart at kigge over på hjemmesiden, og i dag gør jeg det, fordi at de ting, vi snakker om her, er listet op i artiklen på hjemmesiden. Der er mange parametre i det her, og det er svært at høre det alle sammen, eller høre detaljerne i det alle sammen. Men så derfor er de listet op, sådan at du ikke behøver at huske det hele udenad. Det her er som sagt afsnit nummer 96, så noterne finder du på SIVP.dk/96, SIVP.dk/96, og så over til interviewet. Hello Stephen, and welcome to the podcast.
Hello, good morning.
Thank you for being here and taking the time out to talk to us.
Yes, absolutely. It's a bit of a time difference for us, but I think we're making it work, so this will be fun.
Yeah, so I just got home and got off from work, and your day is just starting, right? So,
Just showered.
so it's a bit of a time travel, but I'm very thankful that you want to use some of your time on us, and hopefully people will get the money worth for taking the time to listen to us. So I'm fairly certain that they will. I know you give lectures and you do teaching and you have a lot of online activities as well. So I know that you are used to teaching and telling other vets about your subject. So I know this is going to be a good one. So I was in contact with you to talk about monitoring under anesthesia. But for people who don't know you, it might be beneficial to start off with a short introduction, so people will get to know you a little better.
Sure, great. So my name is Stephen Cital, and I am from California in the United States in a place called San Jose. And I am a RVT in this state, and I am also a holder of a surgical research anesthetist certificate, as well as a veterinary technician specialty certification in surgical anesthesia. And I have a few other letters behind my name, but that's just annoying. And those are, I think, the important and pertinent ones for this podcast. I currently work at a specialty hospital full-time and do consulting for research organizations and zoos. And as you mentioned, I'm pretty active in the veterinary community. I help my good friend Tasha McNerney and Darcy Palmer run the Veterinary Anesthesia Nerds page, which is on Facebook, where people can post questions related to anesthesia and pain management. I'm also the executive director for the Academy of Laboratory Animal Veterinary Technicians and Nurses. And I don't know, do a few other things, do some research, do some writing, and definitely do some lecturing. So kind of all over the place. And hopefully some of my knowledge can be shared today.
Mm-hmm. And you also are putting together a symposium, right?
Oh, yes. We have our Veterinary Anesthesia Nerd Symposium October 8th and 9th of this year, and this is our third one, so we're pretty excited about that. We have Dr. Fernando Garcia, who's a veterinary anesthesiologist, and Dr. Mark Barletta out of University of Georgia, who is also an anesthesiologist, and so we are excited to hear them present.
Mm-hmm. And if we're going to talk about how to monitor some of our patients better, or what to look for in during anesthesia, where do you think we should start? It's a kind of a broad question, but there's a ton of different topics that we could start off with.
Sure. So it kind of depends on what setting you're in, whether you're in a more rural setting, if you're out on the farm, if you're doing standing anesthesia for larger animals, or if you're in a small clinic in the city, or if you're in a big specialty referral hospital or an academic setting. I think the art of monitoring anesthesia is all the same, whether you have all the nice new machines or some of the old machines, or maybe you don't even have any machines at all. It's really going to go back to the anesthetist and using all of their senses, their sense of sight and feel and touch and listening to their animal under anesthesia, even if you don't have those monitors. So it is palpating and ausculting our patients, their heart rate during anesthesia, watching the respiratory rate, looking for those minute changes in respiratory rate and maybe effort under anesthesia if they're not under a ventilator. As far as tools go, I think some of the absolute basics or basic instruments that people can have in their clinic are certainly an SpO2 monitor. So we're looking at the oxygen saturation of our patients and having appropriate technology for that. SpO2 monitors have evolved quite a bit from where they used to be, where we used to only call them random number generators because they would give us these wonky numbers, or you would have it off your patient and it would still be giving you a number and you're like, what is going on? Yeah. But the technology has gotten a lot better and a lot more sensitive and can really provide some valuable information as to the perfusion and the oxygen saturation of our patients. Mm-hmm. And something that I think people don't necessarily appreciate as much with the SpO2 monitors is if you have a larger screen monitor and you see the little wavy lines next to that number, a lot of people don't pay a lot of attention to that, but that's a plethysmogram, and that's a pretty important waveform to kind of look at because that can give you a lot of information. It's funny, when I have cases that I'm running and say the EKG has fallen off or it's not giving us a good reading anymore, and I'll tell my surgeon or I'll tell one of the other anesthetists in the room, hey, it looks like this animal probably has second-degree heart block. And they'll be like, how could you tell this without an EKG? And it's funny because you look at those plethysmogram waveforms, and those should coincide with what your EKG looks like. So if there's a big space in there, I know just because a second-degree AV block is a pretty common arrhythmia under anesthesia, that my patient probably has that. Mm-hmm. The other thing that that plethysmogram can also tell us is, depending on how tall or how short those waveforms are, or if they go from tall to short and short to tall, that may be an indicator that our patient maybe needs some more fluids. Maybe we are having losses somewhere. So it does provide us with a lot more information. So becoming really familiar with your tools and every aspect of them, not just the numbers they produce, can, I think, add a lot more to your anesthesia monitoring experience. As far as like another tool I think is kind of a must-have is the end-tidal CO2 monitor to measure the CO2 output of our patients. And that's going to be really important. That's going to be a good predictive monitoring advice or a device for us in determining the depth and the quality of anesthesia we're providing for our patient and the hemodynamic changes our patient is going through. When we see an increase or a decrease in our end-tidal CO2 out of the normal ranges, that can be indicative of maybe our blood pressure is going south. One of our first vessels that are going to kind of start shutting down or losing perfusion are those ones to the lungs after we get our peripheral losses. And we're going to see that reflected with our end-tidal CO2. Maybe before our non-invasive blood pressure monitoring device gives us a number or a low reading. So we can catch those things sooner rather than later. And I think that will definitely benefit our patient. And then I think one of the most simple things that we have, or that you can go buy at pretty much any grocery store and not necessarily have to spend thousands of dollars for a new device, is a thermometer. Our patient being warm, or at least normothermic under anesthesia, is going to be vital, not only for the physiology of that animal, but also for the pharmacokinetics and dynamics of the drugs that we're using. You know, if our patient gets too cold or too hot, we get these changes in our pH, again, going back to the end-tidal CO2. And when we change these temperature gradients, when we change these pH balances, we're going to change the way some of our drugs are working. So we can change the way our anesthetics are working in a good way or a bad way. So if your patient's really, really cold and then it doesn't seem like they're staying anesthetized well enough, maybe they're too cold and all those little anesthetic molecules are trapped and not able to do their job. So I think a temperature probe is a very simple and cheap form of monitoring that we should all be doing, and maybe we forget about sometimes because it just seems so simple.
Yeah, and sometimes when a lot of people, myself included, are thinking about anesthesia monitoring, the temperature isn't usually what I think of first, actually, because I would think, as you mentioned, heart rate and the SpO2 and the color of the tongue and of course I know that my patient shouldn't be cold, but I don't usually consider it as a very emergency. It's not. It's important, but not that important.
Right. And we also have to think about, you as a surgeon and you're making these incisions, we want really good perfusion and blood flow to those incisions. If our patient's really cold peripherally, we're having all this vasoconstriction peripherally, and your wound's not going to heal as well, or it's not, going to stick together as much, and maybe you'll get more leakage later in the healing process. So yeah, it is pretty vital. And then as our patients are starting to wake up out of anesthesia, if they're super cold, it's just going to prolong that and they're not going to wake up. And you also have to remember, being cold is painful. There's nothing worse than waking up, if you go camping in the morning and your toes and your fingers are freezing. And it's just an added layer of discomfort for our patient that I don't think they necessarily need to go through, because we have the tools to prevent that.
So if we rewind a little bit here, there's a couple of parameters that you have mentioned. So the first one being the SpO2 and the heart rate. And these monitors can be fairly simple, right? That's just a clip you put on the tongue or maybe the ear or where you can place it, right?
Right, absolutely. And the SpO2 monitor, like I said, it's definitely gone through a lot of technical changes. We used to have 2 infrared wavelengths of light going through these tissues. Now we can have anywhere from 5 to 7. We even have devices now that can give you non-invasive co-oximetry. So we can see hemoglobin levels, we can see methemoglobin, carboxyhemoglobin, all these different things that we didn't used to have before without sticking our patient or running it through a blood gas or a co-oximetry machine. So it is pretty interesting what we can get from that now. And, I think we're all familiar with putting them on the tongue or in the ear or the lip, but we can also put it in other places. They have.
I actually want to ask you about that, because I have some dental patients, and having all that on the tongue and more cords than I can handle, and it will keep falling off when I handle the patient. So what else can we do?
Yeah, so a lot of companies make what's called a reflective sensor, and it's basically a flat sensor. So it's not a clip, and it has the 2 lights, or the two little spots, one for the infrared light and then one for the actual sensor. And you can actually shave the base of the tail and tape it to the base of the tail, so it's not even near the mouth or the head, so you don't have to worry about it falling off. Some companies will make theirs kind of like longer, and it looks almost like a tongue depressor. And you can put that in the anus, or you can put that in the cloaca of an exotic animal, and it works really well. So yeah, we definitely don't need to stick to the tongue and the lip and the ear like we used to. I actually hate putting them on the ears because I always feel like they get poor perfusion. The ears are going to be the first thing to go if we have our blood pressure start to go down. And there's a lot of cartilage in there. So I actually don't prefer the ears too much. But with the reflective sensors, I think it definitely opens up where we can put these devices.
And what do you accept? 98% SpO2 or 100, of course.
It's funny, ideally we're always striving for 100. I remember when SpO2 was still kind of new and we didn't know a ton about it. This is 10, 15 years ago. At least in veterinary medicine, we weren't using it, I think, appropriately. And anything over 90 we thought was appropriate, but we now know that that's very incorrect. And we definitely want things at least above like 95, 96 or greater. Ideally, at least in my hospital with our protocols, we want it at 98 or greater. And we strive to move it around till we get that number. So we're not going to get an artificially high number. We can get an artificially low number, but we're not going to get that artificial high number. I think the other thing to think about too when we're talking about SBO technology is when we're measuring the SpO2, even if they're at 100%, depending on the patient's illness or condition, that could actually be false. So when we're looking at our SpO2 number and the number it's producing, say 100%, it's measuring what's called oxyhemoglobin. So it's measuring all the different hemoglobins with an O2 molecule bound to it. But the problem with that is we can have dyshemoglobins, so hemoglobins that are sick that may hold on to an oxygen molecule but not allow it to get into the tissue. So things like methemoglobin that we see with maybe paracetamol toxicity or high doses of metoclopramide, or sometimes if people are still using things like lidocaine that can induce methemoglobinemia, and you can have let's say 5, 10, 15% of the hemoglobin that is turned into methemoglobin. So you would need to subtract that 10% of methemoglobin from that 100% value that you're getting on your SpO2. So maybe their SpO2 is only 90, even though it's reading 100. So it can be a little bit tricky, and we need to understand the full clinical picture of our patient and what medications we're giving them.
Mm-hmm. What do we do, actually? What do we do if it's not over 95? I mean, I can't just blow more air into it, or can I?
Right. Yeah. So if our SpO2 is not over 95, I think one of the biggest things we need to look at is the temperature of that animal. Are they cold? Are their peripheral tissues cold, and is there vasoconstriction? So maybe, their vital organs are getting 100% O2, but their periphery is just kind of cut off from circulation. So evaluating the temperature status of our patient, moving that sensor around to find a better perfused piece of tissue. Their genitals are a well-perfused piece of tissue. Nature always wants you to be able to breathe to the very last second. So those genitals are always going to be perfused, even if that patient is dying, right? So we can put it somewhere in the genital area, maybe the base of the tongue instead of the tip of the tongue. So, definitely move your sensor around and make sure it's real. If you have the option of a second SpO2 monitor, put that on your patient to see maybe this SpO2 monitor is just acting up. We can also, depending on the setting that you're in, if you have super bright fluorescent lights in your hospital, cover the SpO2 probe and the tissue that it's on, because we can get light dilution on our SpO2 monitor, which will give us incorrect readings as well.
Mm-hmm. How about pain medication? Can there be poorly perfused because of what we do to them?
Yeah, it depends on the medication you're using. So if you're using things like dexmedetomidine, which is a great medication and can be used for pain as well, that's going to create peripheral vasoconstriction. So we can see artificially low numbers, but we know that's a side effect of dexmedetomidine. So we just always have to have that in the back of our mind that this is a normal cause and effect from this medication, whereas other medications like opioids, those create vasodilation. So I wouldn't expect to see low numbers just because we gave something like an opioid. Other medications like nonsteroidal anti-inflammatories, we don't necessarily expect to see effects from that. And I can't really think of any other medications that might change things. I think dexmedetomidine would be the big one. If we do a large local infiltration of something like lidocaine or bupivacaine, and we have the sensor really close to where we infuse that tissue, you may be able to see a change, but we typically don't do that anyway. So shouldn't be an issue.
Okay. And the reason why I keep asking around this monitor or these parameters is because I know a lot of vets in my audience anyway, that is what they have, aside
Sure.
for a thermometer, of course. But this is it's just fairly simple and not too costly equipment to have. One more thing, how about the circulation, the heart rate? If it goes down and the perfusion seems to be poor,
Right.
That must be a bad sign as well, right?
Yeah, so when we're looking at our SpO2 monitor, and most of them give you a heart rate on there as well. And remember, we can use those wavy lines, the plethysmogram, to kind of gauge the perfusion or the pulsatile quality going to those peripheral tissues. We should start looking at our patient. Maybe our patient is too cold. Maybe the anesthesia is too much, and we should titrate it down and wean it off of the anesthesia a little bit. Maybe the patient is hypovolemic. They need more fluids. It's not uncommon that we have older animals come in with a packed cell volume of something in the 50s, and maybe we need to give them more IV fluids during the anesthesia procedure, or give them a bolus of crystalloid fluids to help with their perfusion and kind of dilute things out and get things pumping. We can have poor perfusion, but a pretty high heart rate. So, when our patient becomes hypovolemic, we normally see tachycardia. And just because our heart's beating really fast doesn't mean that our blood pressure is good, our organs are getting appropriately perfused with oxygen in that blood. So, definitely start with looking at your monitor, make sure we actually believe that number that's coming out, looking at our patient, using all our senses, looking at the gum color and the capillary reflex time or refill time, looking at the temperature of our patient, decreasing our gas, because that's likely going to be part of our problem. And then consider fluid boluses if needed. And then if we get really concerned, we can look at medications such as microdoses of ketamine or dobutamine or dopamine or phenylephrine, whatever we may need to increase the blood pressure. So yeah, we can definitely appreciate that and catch that pretty quick. And lots of methods and first steps to easy steps to try to maintain that heart rate and that blood pressure. The other thing I forgot to mention when we're talking about SpO2 technology is some monitors, in particular if they're manufactured by a company named Masimo, and I think there's another company out there that is doing it now, but they also have a number that people forget and ignore because they just don't know what it is. And it's called perfusion index, or PI, and that's on your monitor. We don't have a lot of good studies validating what that number should be in animals, but at least in humans in a critical care setting, we want that PI number to be 3 or greater. And that PI number is the pulsatile quality in those peripheral tissues. And we have to be careful when we look at PI because we don't want to get overexcited if it's really, really low, just because it is on a peripheral tissue, and temperature and light and where it's placed is going to be a variable in how that number reads out. But it is a cool tool that I think a lot of people forget about when using SpO2, and a technology they may have in their hospital that they just didn't know that they had.
Yeah. So the machine give us a number. I have no clue what it means. I just disregard it.
Right.
Right.
Yep.
Then you talk about was it the capnogram, the volume air that the patient blow out, or?
Yeah, it's the amount of CO2. So when we're looking at capnography, for every breath we take as mammals, right, or even birds, except they have a 2-breath cycle, we take in this oxygen, our cells use this oxygen, it creates this waste gas, the CO2, and then we breathe it out, and we expect to have a normal amount of CO2 coming out with every breath. If we have too much CO2 coming out, maybe our tissues aren't being perfused enough, maybe we're not getting enough oxygen to our patient. And when we start to see those high levels of CO2 coming out, anything greater than 50 here in the States, I believe you guys use a different value over in Europe, don't you, for CO2?
Yeah.
I don't remember what it is off the top of my head, so I'll just use the American version. But we typically look for CO2 and end-tidal CO2 between 35 and 45, and whenever we go above 50, maybe even 60, that CO2 can act like an anesthetic gas and make our patient deeper under anesthesia. So it's really important that if we don't have a ventilator on the patient, that we're giving intermittent breaths to our patient to flush that CO2 out, because we don't want to make our patient deeper. Also, when we have high levels of CO2, it is changing the pH, so it's changing the acidity of our blood. It's making it more acidic, and we know with climate change and whatnot, our oceans are becoming more acidic. And what happens to our oceans when they become more acidic? It starts to kill things, and Mother Nature doesn't do its job. Well, our body is the same thing, and our blood is our ocean. So when our blood becomes more acidic, it starts to hurt everything else in our little environment. So we have to be very cautious with that. And give intermittent breaths. And, depending on the patient and how long the anesthesia is, considering whether we want 100% O2 for the entire procedure, or if we can get away with maybe having just regular room air, or if you're on just injectable anesthesia, like I know some practices do, and they don't have gas anesthesia, hooking up an ambu bag so that we can give them a breath, even if it is just room air, is going to help our patient overall with oxygenation, perfusion, and getting rid of those waste gases.
Mm-hmm. And forgive me for maybe asking stupid questions, but the capnogram, is that the one that looks like a skateboard's half pipe, or is it more like the Ayers Rock silhouette?
Yes, yeah, I call them a mesa, because that's like the Ayers Rock or the dome that we see in some of these national parks that we have. But yes, that is that line. That's capnography. So that's like the plethysmogram from the SpO2, and those can be pretty telling as well. So if we're on a rebreathing system, so a circle system, like for our larger animals, we typically want to see that nice plateau look, right? Kind of flat on the top and fairly steep sides. If the patient is smaller and you have them on a non-rebreathing circuit, so something like a cat, we can expect to see those lines maybe like a hill instead of that flat top. And that's normal, and that's okay. And those are very telling, because it can show if our tube is in too deep, or if we have bronchospasm, or we have some sort of blockage as well. So those are nice for us as far as monitoring. But I know not every practice is necessarily going to have that type of monitoring in their hospital.
No. And that's what you put it on the tube. I don't know the English word actually, but you put it on the breathing tube, right?
Yeah, the endotracheal tube. Yep.
Yeah.
Between the main anesthetic circuit and the endotracheal tube.
Yes.
Exactly.
Yes. So, and then you talked about the EKG as well.
Right. So the EKG is definitely a nice tool. And we have the clips that can go in the axillary and inguinal areas or at the very distal pause. And we have those electrode types, and then we also have what's called an esophageal electroprobe. So it's something that we can put in the esophagus so you don't have all these wires around your patient, which is kind of nice. And what's cool about those particular esophageal devices is they're also oftentimes acting as an esophageal stethoscope. Mm-hmm. And also they can act as a temperature probe. So we can get three things with just one tool, which is really nice, especially for our smaller animals. But the ECG is obviously going to be important for us as long as you have someone that can read them. I think we all have a general sense of what an ECG should look like with its three little points. But if we stop seeing those normal complexes, we should be more concerned with how our patient is doing. Is their heart sick? Is their atria sick? Is the ventricle firing appropriately? If we see things like premature ventricular contractions, maybe we need to give our patient more fluids. Maybe we need to give them more pain medications if we see those in our anesthesia event. Are we having different types of heart block? I think what's nice about the heart block that we see with ECG readings is most of the EKG abnormalities, with the exception of tachycardia and idiopathic ventricular acceleration, we treat with atropine. So what's really nice is if our heart rate is too low, we give them some atropine. If we see first degree, second degree, third degree heart block, we give them atropine. So it is kind of nice because we can treat most of these things with just atropine, which is nice and easy for us.
You give it IV?
I do. It kind of depends on the case. I do start out with a 0.02 milligram per kilogram dose of atropine, and I'll give that IV. If it's a longer procedure, I will also give that same dose subcutaneously or intramuscularly, just to get us through the procedure, because the half-life of atropine is pretty quick. It's only about a half hour. So, if I don't want to keep redosing, I'll give it sub-Q or give it IM. Or we can use something like glycopyrrolate as well, which lasts longer. I tend to stay away from anticholinergics in most protocols unless I absolutely need it, because whenever we increase the heart rate with something like atropine or glycopyrrolate, we are increasing that myocardial oxygen demand. So if we have a compromised patient, it's fine that their heart rate is that high under anesthesia because they're getting 100% oxygen when they're under anesthesia and we're kind of in control of things. But if we wake them up and their normal heart rate is supposed to be 80 and we wake them up with a heart rate of 200, one, they feel panicky because their heart rate is beating so fast. And two, if their heart was kind of sick or they're kind of decompensated already, I'm just making more stress for that body because that heart's going to be taking a lot more oxygen for itself rather than for the brain or the liver or any of the other important organs.
Yeah. Good. And then you talked about a little bit about the blood pressure as well. So that plays into some of the other parameters that we talked about.
Right, absolutely. So the blood pressure, my favorite things to monitor during anesthesia that I look for are the end-tidal CO2 and the blood pressure and the temperature. Like those are my three go-tos. If I only had pieces of equipment, I would have those three things, and blood pressure is definitely one of them. And blood pressure obviously is going to be vital for the patient being alive. I have technicians or doctors worry about the heart rate being in the 40s or the 30s for a big Labrador retriever. and they want to treat that heart rate. But then I say, hold on a minute, what's the blood pressure? They say, oh, well, the blood pressure is normal. It's 120/80 with a MAP of 75. And, I say to them, well, the blood pressure is fine. So the heart rate is low, but it's doing its job. It's keeping the pressure up. And we know if that pressure is up, our vital organs are going to be okay. That's not necessarily true all the time. Just because we have good blood pressure doesn't mean we have good perfusion. So it doesn't mean that the oxygen is getting off into the tissue, but in most senses and most of the time that is the case. So as long as the blood pressure is good, I'm pretty happy with other things. And, we need that, especially in our cat friends for normal, kidney health. 20 minutes of hypotension for our cat friends can mean some renal cell death for our cats. And, we may not see that declare itself immediately post-operatively or even within a week, but they come back 2 weeks later and their kidney values are up and you're like, oh my God, what happened? Oh, hey, maybe my patient had some hypotension during anesthesia while they were getting their dental done or getting their spay or neuter done. So it is a critical value that we should really strive to keep as normal as possible. And that's, a lot of times that I would see, at least in smaller practices, having to do with temperature. So keeping them warm and keeping that anesthesia gas as low as possible.
Yeah. And where do you measure? The tail, the front leg, the back leg?
Yeah. So if we think about the vascular anatomy of our patients, and if we're using a non-invasive monitor with a cuff, we want to put that cuff in on an appendage, so like a front leg that is closest to the heart, that has as few forks in the road for that vasculature as possible, because every fork we lose just a micro amount of pressure or reading that we could be getting. So in my perfect world, I really like to have that cuff on the front limb with the little tail on that cuff on the medial side of that limb. Wherever we are putting that cuff, we should put that tail on that cuff over the artery or where we think that artery is, because it's going to be most sensitive there. My second favorite spot is if they have a tail. I like to put it on the tail with the little tag on the ventral portion of that tail. And the reasoning for that is when you think of vascular anatomy, we have our descending aorta, so our heart's pumping, and we have that descending aorta. We have a straight shot to the tail. Whereas if we were to put it on a leg, it's going through all these branches and these other forks and these arterial on this arterial vasculature, and we can lose a little bit of pressure or sensitivity there. So I prefer front limb or the tail, and then if we do have to put it on a back leg, put it over the tarsal region. And not over the calcaneal tendon, which I see people do all the time, which can give us a false reading.
Yep. And maybe we should talk about some of the values as well, because there's three, and sometimes the two of them goes a little up and the other one goes down, and I just look at the MAP and that's just one number that goes either up or down, and that's makes it easy.
I mean, for most cases, looking at our mean or our MAP, our mean arterial pressure is going to be a number that we should pay a lot of attention to. And we typically like to see that in any species greater than 60. At least in my hospital, we raise the bar a little bit and we say we want to see it above 70. So that is a number that we should definitely, pay a lot of attention to. But we should also be looking at our systolic and our diastolic pressure. So our systolic pressure is that pressure, that initial force coming off of the heart. The diastolic is the pressure going back to the heart. And, we need a diastolic pressure. I think that one's the one that always gets forgotten the most. We need a diastolic pressure of at least 40 or greater to get that blood back to the heart and back to the lungs for it to be pushed out again. So if you start to see that number go below 40, we need to do something to help that patient. And that's normally a number we'd see maybe change before we see dramatic changes in our systolic or our MAP. So that's a number to look at. And then our systolic pressure, ideally, depending on the patient and the health of that patient, we want to see that 100 or greater. Depending on the device that we're using, if you have like a Doppler monitor, we're pretty much only getting that systolic number. There's some debate whether we're getting a MAP or the MAP in smaller animals or cats. But in general, like our Doppler monitors are only giving us a systolic number. So we typically want to see that above 100. If it's above 100, we're assuming and hoping that our diastolic is fairly normal and that our MAP will also be normal.
Mm-hmm. And I have a whole podcast on hypotension just in of itself. So maybe we shouldn't go too much into detail here, but can you shortly mention what would you do to get it back up?
Yeah, depending on the reasoning for hypotension, I think I mentioned earlier, we want to assess the patient, make sure we really think the numbers are real. If we get a low value, do another reading right away and see if you get that same number or a number that's pretty consistent with that. And then play with your monitor a little bit to make sure it's on a limb that's not tied down to the table, or there's not too much weight on it, or it's way above the heart, which is going to skew your numbers. But also looking at your anesthesia, our gas anesthesia is one of our most cardiorespiratory depressive agents. And when we use high levels of it, we can unnecessarily drop our heart rate and our blood pressure. So maybe titrate down our anesthesia, maybe adding a little microdose of dexmedetomidine or ketamine or an opioid so that we can turn down that gas and increase that blood pressure. If we're doing a surgery and the patient was maybe a little dehydrated before surgery, or there's a lot of blood loss, we can be dehydrating our patients. So maybe we need to give some fluid boluses. I typically like to start with 5 milliliters per kilogram of a crystalloid fluid and see how my patient does with that. Or maybe I need to turn up the fluid rate in general for my patient. So I think those are the big three things that we can really focus on. And I would say a lot of times those will solve your problem. For some of our more critical patients or really long procedures, we may need to use something like vasopressors or inotropes to increase that blood pressure. But I think with careful titration, good monitor placement, and fluid boluses, we can accomplish a lot.
Mm-hmm. Just two small questions in regards to this. How often do you set the machine to run a cycle?
Sure. So in my hospital, we run it every 2 minutes. We may not record it every 2 minutes. We may record it every 5-10 minutes, depending on the case, but I do run it at least every 2 minutes. If I'm more concerned with a patient, if they are a risky anesthetic patient, I get really crazy and I place an arterial catheter and I do invasive blood pressure monitoring, which I know a lot of practices don't have. But if I'm really concerned about the patient, I think it's a good time for a specialist to step in and potentially, do more invasive monitoring for that patient.
Yeah. And then sometimes I don't know, I'm not supposed to call it Velcro, but it's the hook thingy that's on the thing there. Sometimes it doesn't lock too well, and we just put a little bit of tape around it. Is that going to interfere with the measurement?
Yeah, so that is a very hot topic, and there's a lot of different opinions on that. Yes, so certainly we can have the Velcro or the sticky stuff not work for us as well. And the important thing to think about that is I'm definitely a person that will use just a little bit of tape. I will not put tape all the way around the cuff, but I will put enough tape to where it's holding the cuff on. Some people will put, do you call it elasticon there? The stretchy...
it's called Vetflex here in Denmark.
Vetflex, exactly. Yeah. So Vetflex, I'll put a piece of Vetflex around it very loosely so that it can inflate, but I don't want to put that tight, because anything tight that we put on there, whether it's a Vetflex or the tape, is going to skew our numbers. So if you're going to use tape, which is not very stretchy, just do a little piece so it just holds that cuff on. If you're going to use Vetflex, put it all the way around, but keep it fairly loose, not tight.
Yeah. And I think maybe the blood flow to the leg will go down, and then we will have a skewed number, even though the patient might be good.
Right.
Yeah. I have maybe an oddball question here as well, but is there anything else you think is important to mention here?
Yeah, I think the big thing that I'm really trying to push for that makes an anesthesia event a lot safer for our patient is coming up with really good pre-medication and protocols. So having pain medications like an opioid, adding something like a benzodiazepine, whether it's midazolam or diazepam, are really going to benefit your patient because we can use less induction agent, whether it's alfaxalone or propofol or etomidate or whatever you're using. The more we can decrease those big anesthetic agents with a balanced preoperative protocol, I think we're going to have a more well-rounded, better anesthesia with less complications instead of using high doses of things. When we use high doses of gas anesthesia, we expect to see cardiorespiratory depressive effects. We get poorer perfusion to peripheral tissues. It's exposing your staff to more waste anesthetic gas, which isn't good. So I really emphasize really good balanced anesthesia protocols, and we can mitigate a lot of these negative side effects that we'll see from our patient, which goes back to what we're seeing on our monitoring.
Yeah. And that's actually a very good note to end on. And I just mentioned I have a small question. Is because I'm curious. At specialty clinics, are they called that? Specialty. Okay, sorry. Do you use blood samples as monitoring as well? Do you do on site?
It depends on the case. So I would say for most of our surgeries, no, we don't necessarily do that. But if we're doing something in the lungs or we're doing a heart procedure, we may take blood from an artery to check blood gases. Absolutely. Or if we're concerned that our patient is bleeding a lot, we can run a packed cell volume and look at hemoglobin levels to see how dramatic that change is going to be. But I wouldn't say it's very common. Maybe for our neonatal animals or our diabetic animals, we'll take a little bit of blood just to see how their blood glucose is doing, to see if we need to add dextrose to their fluids or not. But in general, I wouldn't say it's very common.
No. Okay. So you have three values that are three parameters that you aim for, and then you're mentioning to use good pre-medication to.
Absolutely.
Yeah. And the three values was, can you have them one more time?
Yeah, our temperature, our blood pressure, and our end-tidal CO2.
Perfect, thank you. And I've been a member of your Facebook community for some time. I haven't been too active, I would say, because this maybe I don't have too much knowledge to share, but I learn a lot from reading what other people write. But maybe we should talk a little bit about that as well. If people have a question or think they can learn something or have a case, they need to get some feedback.
Yeah. So the group is called the Veterinary Anesthesia Nerds, and we spell it the American way. If you type in anesthesia, so it won't come up the European way of spelling. But it's a forum for veterinary professionals and only veterinary professionals. Everyone in that group is a vet nurse or a technician or a veterinarian or a surgeon. And we have, quote unquote, expert anesthesia specialists kind of monitoring the boards. And if you pose a question, the community chimes in, and then we have some of the specialists also chime in. So it's good free advice. And we encourage anyone to ask any level of question, whether it's very, very basic or very, very complex. I think we have a community that can respond to any sort of question like that.
And how nerdy do you need to be a member there?
Well, here in the States, nerdy is it used to be a bad term, but now we've adopted it as a good term. So you can be as nerdy as you want or not as nerdy as you want. We won't discriminate.
Okay, good. But we have the same thing here.
Nice.
Yeah. Is there anything else you'd like to mention? I know you have a website and you mentioned the symposium as well.
Yeah, so, I have a personal website. It's StephenCital.com, StephenCital.com, and I have some links to different resources on there, and you can see who I am and what I do, and I have some other podcasts on there. I'll be sure to post this one on there when you get it to me.
Perfect, thank you.
And then we do have the Veterinary Anesthesia Nerd Symposium, which is very exciting, and we have that in Las Vegas every year. And I know Tasha and I and Darcy were talking with some friends over in the UK, and maybe we'll be in Europe in the next couple of years.
Good.
So that'll be very, very exciting, and I hope that happens. But yeah, check out the Veterinary Anesthesia Nerds page, and we'll see you there.
Husk, at du kan finde links og noter på hjemmesiden i shownoterne til dagens afsnit. Det er nummer 96, så dem finder du på SIVP.dk/96. Og der er de her forskellige parametre, som vi snakker om i dag, listet op. SIVP.dk/96. I næste uge skal vi snakke om adfærd. Det ved jeg, at nogle af jer har store udfordringer med og har spurgt til, når jeg spørger, hvilke emner jeg skal tage op. Og derfor har jeg fået fat i Katrine Hammer fra dyrlægeskræk.dk, og vi skal snakke om, hvordan vi kan reducere det, altså dyrlægeskræk i klinikken. Men det tager vi mere om på søndag. Vi høres ved.